Great. A full house, so I think and we've got three Health Authority Renal Program presentations, so we're going to get started. These are HARP, or Health Authority Renal Program presentations. Remember that if you do have a question for any of the speakers, and we'll have a few minutes between each one, put either your question in the chat or raise your hand. And if you have any troubleshooting problems, call Sidoni. We have three presentations, one from Fraser Health, Dr. Henry Wong, who's a nephrologist practicing in Fraser Health based at the Abbotsford Regional Hospital, and Alexandra Kruthaup-Harper, who's a master's prepared RN with 25 years of nephrology experience, mostly in hemodialysis, and she's worked on several renal palliative care projects over the last 3 years. And then we have Jun Valentin, who's a registered nurse with 30 years of experience in critical care and nephrology, and has practiced across Canada, the US, Philippines, and Australia, brings a global perspective on improving patient outcomes. And we have Doug Matsell, who's a professor in the Department of Pediatrics at UBC and a member of the Division of Nephrology at Children's Hospital for the last 22 years, and former head of the division and former head of pediatric transplantation. Last but not least, from the island, we have Kelly Picard, a PhD dietitian with a practice in rural renal nutrition and working at Island Health as a renal dietitian coordinator. So there's lots that we're going to hear about from the various health authorities. And with that, I think I'm going to pass it over firstly to the Fraser Health group. And before I do that, I just want to acknowledge that I'm here hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, Tsleil-Waututh Nations and the Métis Charter Community of the Lower Mainland region. And importantly, in this time of flux and atmospheric rivers, we are yet again reminded of the importance of taking care of the land and the people who have cared for it since time immemorial. And you should all reflect closely on what we and people injustices. Next slide. So with that, I believe I'm turning it over. Oh, I'm off. Jun and Henry and Alex first, and then Doug, and then Kelly. So over to you guys.
Morning, everyone. My name is Alexandra, and with Dr. Wong and June, we are presenting to you today on our target weight correction protocol for hemodialysis patients at a Lower Mainland community dialysis unit using bioimpedance analysis. So we wrapped up data collection on this study in the summer, and today we're presenting just the preliminary high-level results of the study. We have our learning objectives here in front of you. And primarily our objectives focused on investigating whether the use of a bioimpedance analysis as a quantitative measurement of hydration status was effective in improving fluid management in our hemodialysis population. And we did this by focusing on target weights and looking at our comparison between medically established goal weights and using the bioimpedance device. We wanted to look at, could we improve symptomatology of patients' experience, so minimizing it, and could we improve thereby better patient outcomes. The second focus was on determining if a fluid removal protocol using bioimpedance analysis could be safely implemented. Our timeline was the study ran 6 months, and in that time, the first initial period was about 6 weeks, where we just focused on looking at our individual participants, reviewing run logs, getting a good assessment of their fluid status. And then we applied the bioimpedance spectroscope at baseline and took measurements there, and then every 6 weeks thereafter. And for our study design, our primary goals was looking at the bioimpedance analysis measurements to improve our target weight outcomes, and then comparing our baseline findings, so current goal weights that were medically derived and assessed compared to the device, and then also looking at applying a systematic approach to guiding our target weight using a protocol, and we refer to that as the target weight correction protocol, and that incorporated using the bioimpedance device. Our secondary goals we will touch on today, but we won't be presenting on them in great detail. Our population was derived from our local community dialysis unit, and we focused on screening the morning and afternoon participants, so about 100 patients in all, to see of those who was interested in joining the study. So we had 44 who consented to the study, and we were able to complete baseline data on them. And then over the duration of the study, there was 9 who we lost in attrition, 4 to transplant, 2 who transitioned to different modalities, and unfortunately 3 who passed away within that initial first 6 weeks, but was not related to the study. To start with, just a very basic overview of what bioimpedance analysis is. So it's a technique that's used for assessing overhydration and body composition, and it uses very simply electrical signals. It's non-invasive. The electrodes, you got 2 placed on the wrist, 2 placed on the ankle on the same side, and the output that you get from these testings is fluid status, and more specifically looking at overhydration, total body water, extracellular water, and then body composition, which is looking at your adipose tissue and your lean tissue mass. And now I'm going to hand over my slides to Henry.
Okay, just give me a second while I get control of the slides here. Morning. All right, so Alex has already gone over the bioimpedance machine briefly. The key reading that we're going to focus on is firstly the overhydration, which is a direct measure from the machine. It's a great single time point measurement. It gives you a sense of the acute fluid status of the patient, and of course it guides immediate treatment decisions. So, how much fluid should we take off? We didn't feel that it was necessarily the best tool to longitudinally follow up patients. So after doing research, we decided on using TAFL, which is the time average fluid overload. So over the next 10 minutes or so, I'll just quickly kind of review TAFL, the calculations that we use to run the study, go over the results, as mentioned, just high-level overall findings, and do a deep dive on certain interesting patients, and then finally draw some conclusions, and if I still have time, then discuss some remaining plans. So why did we use TAFL? Fluid status of a patient fluctuates during the week, and we all know that. There's variability in their sodium intake, their fluid intake. The dialysis schedule and the frequency plays a big part. So if you look at the graphic here, before treatment day 1, their fluid status rapidly ramps up. Get dialysis, it goes down. It's a sort of a jagged pattern through the week 3 times. It's not relevant to our study here, but if patients were on different types of dialysis, instead of just IHD, if they were on nocturnal, if they were on short daily dialysis, then the pattern's completely different. TAFL allows study investigators to kind of look at the average fluid overload of the patient, and it's more representative of their chronic status than that single OH value. And of course, it makes is easier to follow because we can also just do the bioimpedance measurement once. So just to finalize, you see the jagged line, which is the fluid status of the patient fluctuating through the week, and then the dotted line in the middle is the TAFL value. So a few calculations. I'd mentioned that fluid overload, the OH value is the key one that we take from the machine. For our study, most of the patients were measured on treatment day 2. So that's, for example, a Monday, Wednesday, Friday patient, that would be the Wednesday. We take the measurement, and so that would be the midpoint there, where before their second dialysis, that's the FO pre. The IDWG would be the weight gain from Monday to Wednesday. And so once we have that, then we plug the numbers into a long, well, we didn't do that. So there's a way to calculate TAFL using 6 different values, as you can see on the slide there. We didn't do that because it entails a lot of calculations, and also we never did a post measurement for logistical reasons. Mathematically, this equation actually simplifies to the bottom one, which you see is TAFL equals the fluid overload pre-treatment minus IDWG divided by 2. And that's the equation we use to calculate our TAFL. How did we determine the target weight? So at baseline and all of the subsequent check-in weeks, we first recorded the IDWG on the day of the measurement. Then we used the machine to measure the OH value. We calculated the TAFL using the formula that I just mentioned. And then we waited until the end of the week. So this Monday, Wednesday, Friday patient, we wait till Friday and use the post weight on Friday as what we call the patient's current weight. And then we determined their target weight using the bottom equation, which is that end of week current weight minus the TAFL. And that would be the target weight that we would be essentially guiding the patient towards. So a few other additional considerations. We did base our work on Moiso, a paper from 2013. Optimum fluid status, we were trying to guide our patients to a TAFL of plus 0.5 liters. We didn't try to go to 0, again, based on literature, because that has been known to expose patients to dehydration. In order to avoid too many unnecessary small changes in the target weight, we also had a band of plus or minus 0.75 around the target TAFL of plus 0.5. So you'll see a green band in future graphs that would be ranging from TAFL minus 0.25 to plus 1.25. And that would be what we consider the ideal range. It's a busy slide here, but I'll just touch on the first few lines, which is how we kind of separated the patients. So the first group would be what we call the superhydrated patients, so if their TAFL was greater than 2.8 liters. For those patients, if they, in their history, did not have any problems with hemodynamic challenges or too many symptoms, then we would sort of, in quotations, be aggressive with their fluid removal. So aim for 0.5 liters per week, or decrease in 0.5 per week. The second group would be the ones who are either super overhydrated or they were just moderately overhydrated. And then depending on whether they have symptoms or not, again, this would be a decrease of 0.2 liters per week. And then finally, the third group, a fairly conservative group where if they were moderately overloaded, but they had lots of symptoms, we would be decreasing their target weight by 0.1 liters per week. So right off the bat, you can see this is a super conservative rate of fluid removal. And again, this is, so I'll move on to the next slide. Extremely busy, but this was an algorithm that we developed in accordance to something that another group in Alberta actually did. very conservative. Probably that's a point of discussion if we have time as to whether we need it to be this conservative and whether that actually affected our results. All right, so now we'll move on to results. One of the questions we had at baseline was, well, how good are the goal weights on our charts? And so of the 43 patients that we managed to do baseline measurement, you'd have to say we were that was fairly off target. When we did the bioimpedance measurements, only 16 of these 43 patients had a HARP goal weight that was within the bioimpedance target range. We kind of suspected that would be the case, but that this really crystallizes that concern we had about our chart goal weights. Okay, this is a high-level result. So on the left, baseline, and then the every 6 weekly check-ins. You can see right away that one timeline is different from the other 4, and that would be the baseline. Whereas the week 6, 12, 18, 24, they look fairly similar. At baseline, you had 12 patients who were kind of in the euvolemic group, and then the rest of them were either overhydrated or dehydrated. Once we did the intervention at baseline, you can see right away at week 6, that's where we had the biggest bang for the buck in terms of improvement. The euvolemic group went up to 18, and it sort of stayed around that high point, whereas, and then there were subsequent decreases in the other sort of either overhydrated or dehydrated groups. All right, so a little deeper dive into the patient groups. We had 12 patients who were in the euvolemic state at the beginning of the study. So on the graphic here, all these dots were in the target green range. One of the patients got transplanted. 6 of these 12 were perfect patients. So, I mean, by that, they stayed within the green range throughout the entire study. There were 5 that kind of went up and were a bit overhydrated during the study, and then 1 actually got dehydrated. 7 ended up on target. If you kind of the points are only 11 here, so there's 1 patient that I did not include. Started off as euvolemic, but we had lots of problems with. So I'm going to call that patient Waldo because he or she is missing, and we'll kind of go into that later. Okay. Sorry. Oh yeah. So you see this top point here where I highlighted more later. Well, that's the next slide, and that's that blue patient that went from green band and somehow topped all the way to greater than 3 liters TAFO at week 12. So this is what we call the inconsistent patient. So when you look at the TAFO reading on the right side, again, week 0 baseline, perfect within range, and then steady rise to being 3 liters positive at week 12. And then somehow later on went back down to within range by the end of our study. Alex knew this patient well. And so what we found was this patient had no money for food. And so he would have money to pay for food at the beginning of each month. So eat lots, tissue weight gain. And then as the food supply dwindles, he would be drinking lots more fluid. So again, this variability is interesting. Would never have picked that up if I was just rounding and trying to correct goal weights. So this technology, interestingly, actually just kept us on track and illustrated how patient factors actually make a huge difference. And actually, it's not. Oh boy, running out of time here. Okay, I'll keep going. So we had 14 overhydrated patients, and out of that, 8 were successfully
moving it? Is that
guided
right?
down. I need to move. Yeah. Okay. Okay. So overhydrated patients, this is a success story of one who we managed to guide down by 7.6 kilograms over 24 weeks. And at the end, they went into the TAFL range perfectly. Okay, this is a very challenging group in that they were super overhydrated. We could not get them down to our target range. I'm going to highlight two patients from here. The next slide. This is the thirsty patient. I don't have time to go into details, but basically, patient was positive 4.15. Relative success, I would say, we've gone down to about 3 liters, but obviously still very fluid overloaded. Patient was actually very engaged with us, made a lot of lifestyle changes, and that's why his weight actually went down by 8 kilograms through the study. And I would call that relative success, and probably we'd see more if we had been able to persist. Okay, there's Waldo. She's in the dehydrated group. This group to me was actually prompted a bit of clinical thinking and change in how I approach patients, because we actually were dehydrating a lot of patients by our just standard fluid removal. So Waldo here started off euvolemic, and because of things we were not doing based on the study, it was a negative TAFL, so it was dehydrated through and through. This is a technical failure of bioimpedance, I would say. It kept giving us negative TAFL readings, which means we were supposed to increase our goal weight. After talking with Alex and the nursing staff, we decided not to do that and just kept the goal weight at current weight, which is why you see these super negative TAFL levels. This just tells us that bioimpedance isn't necessarily relevant or applicable to all patients. All right. The parched patient, dehydrated. This patient actually looked clinically very much like Waldo. So again, just to highlight, not all patients are the same, and even some that looked fluid overloaded were actually quite dehydrated. And there was a very painful 3.1 kilogram increase at the very beginning of the study that we managed to convince the patient to accept, and she did very well and stayed in the euvolemic range. Okay. All right, I won't go over the slide, but essentially these are potential patients who would benefit from bioimpedance. Probably easy to look at the graphics. And quick limitations. We were a dialysis, community dialysis unit. We didn't include other patients, for example, hospitalized ones, or the in-center ones that would be more challenging with their fluid status, small sample size. Neither the patients or the investigators were blinded. So you can argue, was improvement because of the protocol, or was it because of actual patient factors? And of course, 24 weeks wasn't really enough for the really overhydrated patients. Okay, conclusions here. What's important? So I would say it can be useful as an additional tool to help with fluid assessment in hemodialysis. Problematic if patients are high BMI or really lean tissue mass. I think there's some prospects in creating patient profiles, so then we can identify patients who actually would benefit from this technology and serial tracking. Avoiding dehydration is probably just as important as removing enough fluid from our patients. And then it's really important to get sufficient staff buy-in, get patient engagement, and then of course have unit champions that kind of drive this type of technology. This is not something we have time to go over. So before we finish, I'd like to thank my team, without whom we couldn't have done this. Two clinical nurse educators, Heidi and Jun, who did a lot of the grunt work in the baseline, especially Jun, who did a lot of the hard work in writing a proposal, liaising with administration. Two nurses, Preet and Alex, who were the ones who were talking to patients mostly and doing the bioimpedance measurements, especially Alex. Again, wouldn't have been able to do this without her because of how she engaged with the patients, how they trusted her and therefore accepted the technology. So again, having a unit champion is key if you were to introduce this kind of technology. And I'll stop. We'll take questions. Thank you.
Thanks. We just have a few minutes for questions. I guess one of the things does anyone else have questions? I was going to ask about a practical thing. How long does it take to do this? And do you think, have you adopted this as a regular practice in the unit now in terms of setting up the bioimpedance?
So I'll let Alex talk about how long it takes to measure each patient. We have not put into our practice, partly because this study was meant to test it out to see if it's worthwhile, and also tell us how we would implement it. Right? And certainly, I can tell you right away, we would not implement that unit-wide because of the findings. But perhaps in certain patients where we would think they would benefit.
Yeah. So an actual testing from start to finish, if you say include like getting a patient settled, do the testing, write your numbers down, is 15 minutes. The test itself is about 5 minutes. So it can be done like mornings pre-dialysis. I could test 6 patients, juggling their intervals of when they arrive and when they get on dialysis. And then afternoons was always a bit trickier, but again, 4 to 6 patients I could do in a morning. And what I have found since is, patients are interested. A lot of them have said they appreciate that there's a tool that's more quantitative assessment and not just more guesstimate of clinical judgment when it comes to goal weight. And so there is value in it for sure, but again, it's not for everybody.
Well, thank you. I'm sure there's other questions, and I'm going to let people email you directly. I just want to make sure that we have enough time for all of our presenters. So thank you very much, and thank you for the work that you've done on this and to prepare the slides. And I think we'll move on to Dr. Matsell. Thanks very much. You can stop sharing your slide, and then Doug, you can take control. There you go.
Okay, just find my slides here. Go. Browse my computer. It's telling me that it already has mine. So. There we go.
Yep, there we go.
You see that?
Great.
And let me just
grab just loading. There it is. Yeah, perfect.
You got it? Let me just find the pointer here.
Just at the bottom. Yeah.
Bottom. Can you see my pointer?
Yep, we can.
Okay, so let's get started. Thank you, Dura, for the invitation. Thank you, Janice Dion, for inviting me to talk about the CAKUT Clinic. And most of you are probably wondering what CAKUT stands for, and I'll get to that in a second. But the objectives, as stated, I'm really going to make the case this morning for a dedicated clinic for babies with kidney malformations. And in so doing, give you a sense of the clinical profile and complexity of these cases. And also using the CAKUT Clinic as a platform to provide evidence-based care and education and intervention and follow-up. So CAKUT is an acronym for Congenital Anomalies of the Kidney and Urinary Tract. It's crept into our vocabulary over the past 5 to 10 years. And in essence, really, CAKUT is kidney development gone wrong. So interruption in normal kidney development can result in quite a broad spectrum of phenotypes. You see over on the left-hand side, from anywhere from a complete absence of a kidney on both or on a single side, to an atrophic kidney, a multicystic dysplastic kidney, a cystic dysplastic kidney, a hypoplastic kidney, or a kidney that looks normal but has segmental dysplasia. And many of these elements can also be reiterated by congenital urinary tract obstruction, which I'm not going to talk about too much today. So why is CAKUT important? Well, for us in pediatrics, it accounts for up to 60% of our end-stage kidney disease. And a recent article that was published online this week by Franz Schaeffer and IPNA showed that this is pretty much consistent around the world, except for northern East Asia, where apparently the unknown outnumber the number of CAKUT. So I want to take this slide to take the opportunity to acknowledge BC Renal, which used to be the renal agency, and the RRP funding over the years, which has enabled us to assemble a number of different data sets that you can see up at the top here, from which we have been able to assemble a fairly robust historical cohort of kids with CAKUT. It's one of the bigger ones around the world. And we've used these 6 different data sets. It's taken many, many years to do this, many summer students, funding of summer students, with data cleaning, data transformation, and database consolidation. But we've been left with a cohort of 452 kids with the profile of multicystic dysplastic kidney, renal agenesis, hypodysplasia, and posterior urethral valves. So this is notably in this cohort, much like the literature is showing, we looked at a number of different kidney outcomes, recognizing this is a historical CAKUT and with a median follow-up of about 10 years. But you can see that 17% of the cohort developed hypertension, 19% of the cohort developed proteinuria, 28% of the cohort developed chronic kidney disease, 8% end-stage kidney disease. And then we're going to use this terminology of composite outcome in part so that we could increase the number of outcomes for our analysis. And the composite is hypertension or proteinuria or chronic kidney disease or end-stage kidney disease. So we've used this cohort of 452 kids, this historical cohort, to develop a kidney injury risk prediction tool. And we studied the outcomes of proteinuria, hypertension, CKD, and composite outcome. And what we found, and I'm not going to show you all the regression analyses of the mathematics that we did. We published a number of papers on this in the past. But we identified 4 very important variables that are independent as part of a multivariable regression model. And these are primary diagnosis, the estimated GFR at first visit, the kidney size, and whether or not there is additional CAKUT in addition to the primary diagnosis. And we took this regression model and we integrated it into a novel software application. And you can see you can do this on your computer, or you can do this bedside on your smartphone when you're speaking to families. It's a matter of entering all the patient information, which will then calculate and display the primary diagnosis, the estimated GFR, the kidney length, and whether or not there's additional CAKUT. And then it will give you a % probability that this child in the next 10 years or so will develop the composite outcome. So enter the CAKUT Clinic, which we established in 2023 after I returned from sabbatical. And simply put, the objectives of the CAKUT Clinic, one is to actually apply the regression model in the bedside application. But in terms of service delivery, we really have 3 big objectives. One was to confirm the primary diagnosis, because this was important in predicting outcome. 2 was to identify any risk factors that might be associated with a poor outcome. And 3 would be to answer any questions that the families might have, recognizing that most of these patients who are referred are newborn babies. So our referral base and our critical adjacencies include a number of different programs in British Columbia, including maternal fetal medicine, medical genetics, primary care, including family doctors, nurse practitioners, and midwives. We do get referrals from in-hospital, but also we work closely with our urologists who send us patients and our general pediatric colleagues out in the community. And I would say the bulk of our referrals come from our general pediatric colleagues and from our maternal fetal medicine colleagues. So in the clinic, we have a cohort of 221 cases. Of these, about 200 are new referrals. So in the past close to 3 years, we've seen close to 200 new referrals in this clinic, of which about 140, 150 are postnatal referrals. About 50 or about 25% of the referrals are antenatal consultations. And I'm not going to talk about them today. I can do this another time. I don't have time to talk about it, but also a very important part of our referral base. So when you look at the patient profile, the age at which these patients are seen is a median age of about 7 months or 0.6 years. And you can see there's some variation in that. A lot of the referrals, we have a waiting list of about 2 to 3 months. So the referrals usually come in slightly earlier than that. There is a male preponderance in the referrals and in the cases, which is consistent with the world literature. About 2/3 of the cases are male. And the diagnostic profile of these patients is very similar to that we outlined for our retrospective cohort. So when you look a little bit deeper at some of the kidney metrics that we are interested in assessing early on and using to prognosticate and to predict outcome, the estimated GFR of the group is a median of 112 with quite an interesting variation of 2 standard deviations with a kidney length to body length metric, which we've shown is a really good surrogate of nephron endowment and correlates well with outcomes of 0.09, and again, some with much less and some with much more. So armed with the information at the bedside, entering the information into the calculator either before or after the contact, we've been able to personalize the prediction of developing the outcome. So this really is the punchline of the whole talk, is this graph on the right-hand side. On the x-axis is the percent probability of developing the composite outcome. So this is this number that pops out after you've entered the variables into the mathematical model. And on the y-axis are the number of cases that have that probability. And you can see there's quite a distribution across the population. So this is our incident population, not our prevalent or historical cohort. And you can see that there are some cases that have very low risk and other cases that have very high risk. And you'll see that this is an important metric that we use in our conversations with families to determine follow-up and further intervention. So just to test the robustness of the prediction, again, on the x-axis is the percent probability of developing the outcome. The y-axis is the numbers of cases. I've superimposed really the diagnostic categories. So in blue is multicystic dysplastic kidney, red is unilateral renal agenesis, the green is renal hypodysplasia, and the purple is posterior urethral valve, which is very much in keeping with what we would guess when we're in clinic about who is going to go on to develop problems. Interestingly, though, in each category, not all the risks are the same, and the risks in each category are not the same. So the risk prediction score is becoming, so this is a loosely assembled clinical pathway, I should tell you, that I've draped over the past few days in preparation for this talk. But the risk prediction score is really the anchor of this clinical pathway for these kids who are referred to our clinic. So you have a referral and triage process, which again, I don't have time to talk about that. And many of the referrals come in antenatally, so there's another arm to this algorithm. And the initial assessment is quite important. I've been trying to see these kids within the first year of life in the event that something needs to be done sooner. So the recommendation would be to see these kids, practically speaking, in the first year of age. A full assessment, including a physical exam, needs to be done. because we've shown in univariate regression models that the kids that are have these anomalies that are associated with other anomalies and or genetic syndromes have worse outcomes. A height and a weight, a blood pressure, a urinalysis, blood test for GFR, and all of these things are done by our specialty nurses in our clinic. They're hard to do. Blood pressures in infants are hard to do. Collecting urines on little babies is hard to do. Getting blood work on babies is hard to do. So that's justifying the dedicated clinic. And also kidney abdominal ultrasound done to confirm, usually to confirm the antenatal findings, and also to confirm scans that may be done outside of the BC Children's Hospital. Armed with that, we need that information to inform the risk prediction score. In those cases with a low risk, we would argue that these kids could be discharged back to their primary care for ongoing annual surveillance of blood pressure and urinalysis. Those that are, and I use this terminology on purpose, those that are not low risk would be followed up depending on how high their risk prediction score is. And I should say, and if in fact the risk score is very, very high, usually means that the children are well along the CKD pathway and probably would benefit by being transferred to the CKCC clinic. But I find that the risk prediction score and the justification for follow-up or not follow-up is important when the family is engaged and conversations are had with the families about longer-term follow-up. There are some children with very, very low risk where the parents insist they want to continue to be seen by the specialist, and we have some discussions around the risk prediction score and the likelihood that there's going to be a problem in the future. So just to show you some of the fruits of this pathway paradigm. So when we look at the kids that our incident population that we've seen over the past 3 years, we found at initial assessment, 2% had elevated blood pressure, 12% had proteinuria, and 30% had an eGFR that was less than 90 mils per minute per 1.73 meters squared. And interestingly, when you superimpose whether these kids have been discharged or not discharged based upon the pathway algorithm, you can see in red is the discharge, and in blue is not discharged. And obviously the discharged patients tend to lean to the left and represent about 30% of the kids that we've seen so far. And I would argue that these lower risk kids have yet to complete their full assessments, and that's why they haven't been discharged yet. So in summary, CAKUT are uncommon rare diseases, but they account for the majority of the childhood end-stage kidney disease that we see in our clinics. As I mentioned, not all CAKUT have the same outcomes. And I would suggest that the risk prediction tool that we have developed enables accurate disposition of these kids and these babies. And also just to sing the benefits of a CAKUT clinic, I think it provides a dedicated environment where we can gather early clinical information and kidney health metrics that can be done in a specialty clinic. It provides multidisciplinary support. So we have specialty nurses, we have dietitians as needed, we have social workers as needed, as a spin-off of our CKCC clinic resources. And it's also an opportunity to share information with the families. So the clinics are usually once a week. I see 4 patients, sometimes 5 patients per clinic, so I have time to spend with the families. The future work is going to include external validation of this risk prediction tool, because this is just specific for Vancouver and BC. Also, we've had a few initial steps looking at parent-guided, the development of parent-guided information and educational materials. And I put this up just to be a little bit provocative. And I would also argue that in a real world, we would integrate universal genetic testing into the clinic, because we have found without universal testing, about 15 to 20% of the kids that we see either have a phenotypic manifestation of a syndrome, and or they've already been tested either in utero or immediately post utero or postnatally. So I'm going to end there. I want to thank again the Provincial Renal Agency, or BC Renal, and RRP for helping fund this initiative over the years. Thank you.
Thanks so much, Doug. It's really great to see, clinical data being used in a strategic way to improve and inform care. So it's really terrific. Thank you. Look forward to next steps, and I'm just conscious of the time. If there are questions, can people either put them in the chat and Doug can answer them, or please feel free to contact him. But really terrific use of brain and dollar power to improve care of patients in this arena. And obviously, like I think most of us in adult medicine may not usually see these patients, right, given their outcomes. But thank you for that. So last but not least, not used to looking at, is Kelly Picard. There you go, Kelly. So over to you. We did start a few minutes late, so we're not in a super rush. So go ahead.
Okay, thanks so much. So today I'm here to talk about our project, which was about understanding unmet needs at the intersection of diabetes care and kidney disease, and we did a mixed method analysis. And so I'm here on behalf of our project team. So our project lead was Anna Lee, who I think is on the call, and Morag, the QI manager at Island Health. So thank you so much to both of them. And then the other team members that made this project possible. And I'm calling today from Nanaimo, so also in the Coast Salish territories, and here from the Sanemo First Nation. And so what I'm going to talk about today is sort of four main things. So we're going to describe the population of adults living with both diabetes and kidney disease in Island Health. We did some patient surveys, some provider surveys, and I'm going to share some change ideas that we developed as a result of this project. And so just as a bit of background on why we decided to put in the RRP was that clinicians had identified gaps, and we were hearing patient stories about gaps in care when it came to managing both diabetes and CKD. And I guess we really wanted to understand if our experiences were just sort of these one-offs, or if this was perhaps a bigger issue within our health system. And so we used data very intentionally from health records, patient and provider surveys, and our goal was really to understand both the challenges and the opportunities of what was happening with care in Island Health. And our ultimate goal was just that we better meet the needs of the patients and the people that we serve here. And I'm not going to go through this project timeline, but I just had really wanted to put it up. In particular, Anna Lee and Morag worked so hard to be very diligent, thoughtful, and mindful about how we would accomplish the goal of understanding what was happening across Island Health. And I also really want to call out really the support of all the Island Health renal staff that helped make our patient survey possible. Really all of the units came together to help us get the surveys that we wanted out to our patients. And so really thank you to everyone in Island Health and the renal program that supported this project. And so from the health records, what we found, and this isn't really surprising, at least that first number. So roughly 1 in 2 of the patients that are followed in the renal program have diabetes. So that would be exactly what we would expect based on sort of population standards. But this was surprising to me, is that only 17%, or sort of roughly 1 in 6, were actually registered or being followed by the diabetes program. So when you kind of look at those blue versus black figures, you can see there that we've got a lot more black in that second one. And then on top of that, we had roughly 25, or about a quarter, were what we kind of decided to describe as the most complex medical management. And by that, we meant basal bolus insulin. So these are folks that are requiring likely pretty good support to help get their blood sugars to target. And so I'm going to go through a couple slides of what we found out from our patient experience. We were so excited to get 168 people complete the survey. And I will say we were challenged with the mail strike, because some of our surveys went out by mail through Canada Post. And so this overlapped perfectly, unfortunately for us, with the mail strike. And yet we still did we were still really happy with our response rate. And so I know these slides are a little bit busy, but with the kind of mixed method, what I'm trying to show you is our quantitative and qualitative data sort of together. And so what you're seeing here is that what we heard from our patients is 13% didn't have a primary care provider. And then you can see in the quote what that kind of means then for our patient is that they felt like support was practically non-existent when they didn't have this person as part of their care team. 79% have the nephrologist and renal or someone in the renal program involved. And you can see that when that happens, patients report that that's really helpful. They felt supported and they felt like it was great to have that team. And fully a third or just under a third patients reported that the renal practitioner was their primary diabetes management provider. So slightly different than that first one, which is saying that, yeah, we're involved, maybe we're asking, but actually a third of the patients who responded said that, you know, who manages my diabetes? The renal team. And they actually thought that we were doing a pretty good job. You know, they're saying our kidney clinic was wonderful, and the GP was often confused and sometimes dropped the ball. And part, as they point out, is that uncertainty around who's doing what. And so I think that definitely resonated with the stories we were hearing from our patients. But, you know, I guess if we are, you know, for a third of the patients, they're thinking that we're their primary care provider. One of the things that we were really curious about is, are patients then experiencing what would be considered gold standard or guideline directed therapy as far as Diabetes Canada defines in terms of recommended screening and making sure that our patients are getting really high quality diabetes care. And you can see, based on, I kind of just tried to color code it, you know, we're doing actually pretty good about talking to our patients about smoking status, food and beverage intake. Not surprising, because of course the renal program is so supportive of dietitians, so there's lots of us here. But, you know, we start to do less good in some of these other categories. And one of the surprising things for us is how little our patients understood about SADMANS, which is an acronym of the different medications that our patients are being advised to hold to prevent acute kidney injury. And so, while, you know, our programs might not be perfectly overlapped in terms of diabetes care and renal care, it was interesting to us how few of the patients said that they understood or knew what medications to hold if they had been sick. And I guess this isn't surprising that we're not getting, you know, right to target in terms of guideline-directed therapy. And actually, sorry, I should clarify, we as in Island Health. So we weren't asking if the renal program was doing this. We were just asking in general, it was any care provider doing this. But what you can see here from a quote is that a patient then sort of said, sometimes I think I should have received information sooner before the problem comes up. And they were finding very little linkage between their diabetes and kidney care. And I think that quantitative matches that qualitative statement, where there are gaps. We're not getting as high to target as we would like in Island Health. And so these were just sort of two additional quotes from our patients, that the GP's feeling like it's very busy, and that often they actually have other things they need to talk to their GP about, which makes them, even a patient, prioritizing their diabetes care can be challenging. And then just a big shout out to the type of care that folks do get when they come to the kidney clinic is that here's a patient saying, the care I received from the kidney clinic is done in a way I want my diabetes care done, by a team rather than one GP. And I think that does speak just to the value of the multidisciplinary team that the renal program has been able to develop. And so what did our providers say? So we had 84 providers respond. Our provider survey went out to renal program, but also we attempted to get outside the renal program, so our diabetes care providers, primary care, and we were really excited to see a good diversity there in terms of our reach. We were able to get out beyond our renal program, and we were able to capture several disciplines, so nurses, dietitians, pharmacists, physicians, and again, so we were pretty happy with the response. And so what were our providers noticing in terms of the care that was being provided in Island Health? And so 86% said that they thought that they did need more education managing people with diabetes who also have kidney disease. And so you can just see the quote of someone saying, I'd love an in-service. 67% of renal providers didn't feel confident that they could adjust someone's insulin. And if you think again that about 25% of our population are the people who are on insulin and multiple daily injections of insulin, we could see that if the renal provider is the primary provider and many of these people are on insulin and your provider is not feeling confident adjusting insulin, you could see that perhaps there's going to be gaps. And then the non-renal providers, they didn't feel confident about managing diabetes once somebody got to dialysis. And here's a non-renal provider saying that they felt like they're spinning their wheels in their office by themselves. They just don't know who to contact and how to help the patients that they really would like to. And so again, just sort of some quotes is that from a renal provider perspective, we feel like our resources were limited. We really want to focus on CKD management, although there is sort of a bit of moral distress that because we know that diabetes in fact affects CKD progression. And, you know, kind of a vision of like, wouldn't it be nice if we had a clinic where all clinic functions were rolled into one and everything was available, one team, one record, and we all pulled together to really wrap around care for our patients. And so that brings us to the change ideas. And so we really identified 4 key gaps, and including things like fragmented patient records. So not all programs are using our online Cerner system. And then certainly there's limited communication into our primary care, concern about patient burden. But even actually, and again, this was an interesting finding for us, was program mandates in terms of what were the programs actually able to do. And so you can see from our diabetes colleagues, what they said is that sometimes they'll get a referral, for example, to start insulin, but not all diabetes centers on Island Health have an overarching prescriber. So if they go to see the nurse or the dietitian, and as a renal program, we're thinking that they're going to be able to start insulin for our patient or start some medications, they can't because they don't have a prescriber as part of their program, which was an eye-opener to me. We can see also that there was a lack of training for managing the intersection when patients have both diabetes and kidney disease, and that was particularly true for people who are on dialysis and using insulin. And not surprisingly, our patients feel that too. So you can see the quote here where the patient's saying when they started dialysis, their blood sugars were impossible to control, and they felt like they didn't get the support and they were hopeless and alone. And that may in fact have been a completely true sensation if neither their diabetes provider or their kidney provider actually felt confident that they knew how to merge or manage those two things together. We also sort of a gap is that, you know, we do have services to support diabetes care. So we have diabetes education centers. We also have a fantastic program on the island called Community Virtual Care. And, you know, and I think what I pulled out that quote is that when we actually can connect patients with services, a lot of times patients' experience is actually really beneficial. So, you know, how come or how do we get our patients to the right services that are being offered? And how do we, especially from a kidney perspective, make sure our patients understand how to prevent AKI by being familiar with the medications they need to hold? And then our sort of last but not least gap is how do we make sure that our patients get screened for complications? And so our patients don't feel like they've missed out on information that they should have had earlier in their care. And so Morag is hopefully on the call. And so as clinicians, you know, it's very easy for us to just kind of hear this. And definitely there were moments where I felt overwhelmed with all of the data coming in and the sort of the task at hand. And so I was so thankful to have Morag on our team. Who helped us sort of map all of the data that we were getting and making sure that we were thinking about change ideas with the end in mind. So we have an aim, our goal is to improve care. And then what are the drivers that are happening within the system that we can leverage or sort of work backwards in order to get to the sort of our ultimate goal of making sure patients do better on Island Health. And so some of our ideas for change are obviously to do things like provider education, make sure we're looking at screening and self-management, exploring ideas there, and also exploring system level sort of systems within Island Health to understand how do we get patients to the right care, especially when care is being offered. And so our 2 current projects that we are sort of developing at this stage of the process is looking at our provider education and then also looking at something like foot checks, whether that's a visual screening and sort of appropriate referral pathways for our patients. And so I'd like to acknowledge not only our program team, but all of the people at Island Health that helped make this project possible. I really just skimmed the surface of all of the data that we did and sort of the breadth of the project. So I do hope to my project team members that I've done an okay job sort of showing everybody all of the work and the heart, I think, that went into this project. So thanks so much.
That's excellent. And again, a great example of the power of understanding the patients and the healthcare professional points of view in terms of what needs to be done. We do have a few minutes for questions if there are some. These, just looking in the chat, I don't see any hands up. And it is getting to be the bottom of the hour. I think, and to all the presenters, I would say this, the value of these health authority renal program presentations is that ideally we share across the health authorities the sorts of questions that are being asked, how they're answered, and then how we can use those answers to inform when we think that clinics are more the same than different, then how would we in fact inform best or better care in different places. So really a great initiative for sure. I'm looking again around. So at the peak, we had 75 people on this morning's call, and we've still got 67. So that's pretty terrific for a Friday morning in December. Thank you all to the presenters. Thank you to all the teams that made the presenters work so much easier to present. And actually to all the health authority renal programs who really do a focus on everything they can to improve patient care. And for those of you that are on the emergency thing, there are additional road closures in the Fraser Health Authority. So we'll be looking closely in our HARP way to see how we can help our Fraser colleagues if there are issues with dialysis delivery. So again, on that note, thank you very much to all our presenters for the diversity of topics, but also the work that you've done. Thanks again and happy Friday, everybody.